Hi, everyone. Welcome to the PrecisCa GU Tumor Board. My name is Brian Reaney. I'm a GU medical oncologist at Vanderbilt, and I'm happy to be joined today by a prestigious panel of experts from around the country to discuss several cases. I'm going to go around and have everyone introduce themselves before we get started with our first case, and I will start with Dr. Siegel.
Good afternoon. My name is Carrie Siegel. I'm a genitourinary radiologist in the abdominal imaging section at Washington University in St. Louis.
Thank you. Dr. Shaw?
I'm Chirag Shah. I'm a radiation oncologist at the Prostate Cancer Institute at the Cleveland Clinic.
Thank you. Dr. Abel?
Yes, thank you for having me. My name is Jason Abel. I'm a urologic oncologist, a surgeon at the University of Wisconsin.
And thank you. And Dr. Jakaki?
Hi, everybody. I'm Alexandra Drakaki. I'm a GU medical oncologist at UCLA. Happy to join you today.
Thank you all for being here. So we have several cases across the spectrum of GU cancer to discuss today. And we'll start off, and I'll sort of describe the case and the question, and then we'll go through some specifics of the case. And then I'll come back to all of you for an opinion, depending on what the specifics of the case are. Let's move on to our next case. 59-year-old man presents with gross hematuria, has both metastatic prostate cancer as well as locally advanced muscle-invasive urothelial cancer. Gets anti-androgen therapy, neoadjuvant chemo and cystoprostatectomy with lymph node dissection. Then 2 years later has biochemical-only progression, gets initiated on darolutamide with PSA response. So it's certainly a unique case with two cancers. And so the question is really around, presumably when this patient has his PSA rise in the future, then what would be the next steps? So going back, this patient presented with gross hematuria for 3 months, ECOG performance status unknown, gets an office cystoscopy, which shows a large papillary bladder tumor, and CT urography is obtained. Dr. Siegel, I'm not sure what you can tell from that CT urography, but maybe you can comment on the images here.
Sure. Well, we have a coronal and an axial view from a combined nephrographic and pyelographic CT urogram study, and we can see on the coronal view there's just a very large lobulated mass involving really kind of the majority of the bladder. On the axial view, there's a large amount of left external iliac adenopathy. And with the two primaries, the bladder cancer and the prostate cancer, I would think with the large mass of the bladder mass on the right, I would expect there to be lymphadenopathy on the right. So I'm just guessing that this lymphadenopathy might be from the prostate cancer, but it'd be something that we could easily access with ultrasound guidance.
Excellent lead into what happened. So you're right, the inguinal adenopathy was sort of out of disproportionate and sort of on the wrong side, undergoes an inguinal lymph node biopsy, has metastatic carcinoma consistent with prostate primary, then of course gets a PSA checked, it's over 1,000. So clearly has advanced prostate cancer, somewhat uniquely has a bone scan with no evidence of METs despite a PSA of 1,000. Then undergoes a transurethral resection of a bladder tumor, has invasive high-grade papillary urothelial with focal micropapillary features and minute focus of carcinoma in the muscularis, maybe favoring prostatic adenocarcinoma. So again, sort of a mixed histology, if you will, although in the bladder, predominantly urothelial. Undergoes a prostate biopsy with 100% of his 14 cores involved with prostate adenocarcinoma and a Gleason 4+5. Is 9, has some obstruction, gets a nephrostomy tube placed, gets put on combined androgen blockade with bicalutamide and leuprolide initially, and gets neoadjuvant therapy. So I guess maybe a question for, I don't even know, for Dr. Jakaki. You've got advanced prostate cancer, right? PSA 1,000, Gleason 9, and you also have locally advanced urothelial cancer. So how do you, we kind of know what happened, but how do you think about this patient in terms of their competing risks and which to approach first?
Actually, again, I have a couple of similar cases. I have patients that have metastatic prostate and metastatic bladder, but I had a similar situation where actually I gave neoadjuvant chemotherapy followed by cystoprostatectomy and node dissection to get one cancer out of the way, so we can then focus on the metastatic prostate that you expect that will have prolonged life expectancy. So I think the approach of this case is reasonable, and this is what I would have done as well. Oftentimes, in my patients, I can just start with Lupron and chemotherapy, not necessarily dual ADT, just because the chemotherapy component will take care of both cancers, and you can follow the trajectory with the PSA and save the dual ADT for later on.
Yeah, fair enough. Yeah, and if the prostate cancer treatment is likely palliative, then it's easy enough to start on hormone therapy. It's not going to interfere with his neoadjuvant chemotherapy.
Exactly.
And then I think you could sort of treat him as standard. So I think that's correct.
What is very challenging, though, in those cases is when we repeat scans down the road, you never know what is prostate, what is urothelial.
Right.
If the PSA still stays low, doesn't mean they don't develop this neuroendocrine component. So you always want to biopsy, number one, to exclude urothelial, number two, to make sure the adenocarcinoma did not differentiate to neuroendocrine small cell, where you need to approach it with a different systemic therapy.
Yep, agreed. At least at this point, this patient makes prostate cancer makes plenty of PSA, so it should be a reasonable marker, at least at this point. So now we're at the stage of the case. The patient has undergone 4 cycles of gemcitabine cisplatin and androgen deprivation therapy, and PSA has responded wonderfully to almost undetectable levels. And Dr. Siegel, I'm not sure if you can tell, these are restaging after neoadjuvant therapy, and I don't know if you can describe what you see here.
We also have combined and nephrographic and pyelographic phase CT urograms and a coronal and axial view, and it's markedly improved. The problem is it's very difficult for us because you can still see sort of a lobular irregular mass along the right bladder wall, and how much of that is residual tumor, how much of that is post-treatment changes, or even some hematoma or inflammation from a biopsy. It's very difficult on a CT for us to sort of tease that out. And when we look at the axial view, the lymphadenopathy is near resolved.
Dr. Abel, we often do scans after neoadjuvant chemo. I think from a medical oncology standpoint, I'm just making sure that there's no distant disease. Certainly if they had lymph nodes like we talked about with that other case, that's a little different story. From a surgical standpoint, like what information are you getting from these scans?
Yeah, I think that's a great question. It's really the absence of progression that we're looking for. I think that a lot of the stuff you can get off the physical exam, and this patient, this patient is my patient, and looking at this, we could tell that, you know, maybe there's some residual disease in the bladder or suggestion of residual disease in the bladder. It's not going to change our mind. The only thing that would change our mind as far as going to surgery in this patient would be if they had gross progression somewhere else that we were not going to fix.
Okay, so sort of gross, local, or obviously distant progression, and then we're aborting and giving them systemic therapy.
Yep.
So this patient does get a radical cystoprostatectomy, lymph node dissection. The path that I read to you, high-grade urothelial, also prostate adenocarcinoma with androgen deprivation effect, not surprisingly. 3 of 48 lymph nodes involved with prostate adenocarcinoma, but presumably not urothelial. So let's start there, Dr. Abel, since this was your patient. Is 48 the normal number of lymph nodes that you remove, or was this exceptional given his sort of multi-histology?
I think that's probably right. It's tough because the absolute number really varies on how many packets you send in, how many the pathologist has counted. So I think maybe it's a little bit more. We were a little bit more extended in our dissection, but I think that's probably about right.
Okay. So I guess the good news from a bladder standpoint is the patient we're not given the pathologic stage, but presumably T2 or T3 bladder, but not node positive bladder. So hopefully the patient's potentially cured, but then 18 months after surgery starts to have a PSA rise from what it was a low level, almost undetectable, to 1.38. He's watched at that point. In 6 more months, it jumps up to 10.1. Gets conventional scans, which is reasonable, which doesn't show any progression, and then gets put on darolutamide with a PSA response and undetectable now 3 years post-diagnosis. So maybe I'll stop and ask Dr. Siegel, So we're now in the area where we call bone scan and CT conventional imaging, and obviously we're heading towards PSMA PET and oxygen PET, et cetera. And this is really for anybody, but I'll start with Dr. Siegel. If you have a PSA of 10, a rising PSA of 10 in this complex patient, what's the role of non-conventional imaging? PSMA PET or oxygen PET. How's it? What's the likelihood of it being positive? How maybe is it being used in this circumstance? What are you seeing at your institution?
So PSMA PET works very well and works better and better with higher levels of PSA. And with PSA levels, even over just 2 or 3, the accuracy is very, very high. The problem that we run into is occasionally doing PSMA studies on patients that have values between 1 and 2, where the accuracy dips down a bit. It's still good, but it dips down a bit.
And Dr. Drakaki, are you using this imaging in your? I don't know if you have PSMA PET available. We don't yet, but we certainly have oxygen PET, and I think we're all trying to figure out how to use it. I guess I'm wondering, in this patient, would you use it? Would it make a difference in terms of how you approach the patient?
Yeah, actually, UCLA and UCSF were the 2 sites that the FDA approved PSMA December 1st. So we really use it a lot. And even with the PSA much lower than the 1.38, there are nuclear medicine colleagues recommend above 0.18. We can start offering PSMA. The detection could be 30%. So definitely with the PSA of 10, if the conventional imaging is negative, we will offer PSMA. With the whole idea is, can we find oligometastatic disease to offer radiation? So typically, if there are less than 5 metastatic sites, we try to combine radiation with hormonal therapy, with the goal again to keep them on the lowest possible PSA.
So I was gonna ask Dr. Shah that question, which I will in a second, but
I'm sorry I took the answer.
No, that's okay. Do we know there's benefit to radiating those oligomets as detected on PSMA PET? Do we know we're benefiting the patients by radiating those let's call them early lesions?
So it's a great question. So there's actually a paper that just published looking at PSMA PET directed SBRT for oligometastatic prostate cancer. It was not a direct comparison. So they did not, give half the patients PSMA directed SBRT versus not, but that paper showed the feasibility and high rates of progression-free survival, albeit with short endpoints. I think it was a 6-month endpoint. So I think there's going to be more data needed, both comparative data, long-term follow-up data. Oriole, which was non-PSMA directed study looking at SBRT, was published and again showed improvements in progression, but further follow-up is needed because SBRT obviously can only be given in certain ways and increases the cost of care and also offers the potential for toxicity. So it's an area of active investigation, separate from the Stampede idea, which was to treat the prostate. Oriole and some of these new studies are looking at treating METs. And There's also a group treating both the prostate and the MET. So kind of different parallel tracks going on in this space.
So do you think the definitive studies will ever be done, i.e. randomized studies to prove benefit? Or do you think, as I suspect, we'll just start doing PSMA PET on everybody and then radiating everything we find?
The optimist in me hopes the former. The pragmatist in me probably thinks the latter.
Yeah, so I think that's likely. I agree with you. I think that's likely to happen. But I would love to see some definitive studies. It's difficult because it sort of makes sense to radiate early disease, and if it's limited, and et cetera, et cetera. But as you say, it brings cost for sure, potential toxicity, and we want to make sure. Every other drug standard is to help patients, right? Improve survival, whatever the endpoints are. You could argue what the endpoints are, but I just wonder how this is going to unfold. So that was a tangent off into PSMA PET. So this patient did not have that. They had conventional imaging, did not have radiation or anything, got put on darolutamide and had an undetectable PSA. Now we're 3 years out. And so I guess the ultimate question was about further progression. So let's assume this patient has, bony progression, or probably more likely nodal progression in this patient. Let's assume it's all prostate cancer. Dr. Drakaki brought up the good point that in this patient with dual histologies, that biopsy of recurrence is probably going to be necessary. just to prove, because this patient was certainly at high risk for TCC recurrence as well. So I don't know if Dr. Drakaki, you want to take this one. It's a little bit theoretical in terms of what might happen in the future, but metastatic prostate cancer, progressing on, say, LHRH plus, pick your favorite, darolutamide, Abi, Enza. Do you have a general approach? Do you go more hormonal therapy? Do you go early to chemotherapy? Or does it depend on the specific patient?
So I would like, if possible, and if patient doesn't mind the cost of checking ARV7 mutation, we try to see when you're already on ADT, if you are to develop an ARV7 mutation, you may not respond as well to a second generation and the androgen. So maybe giving chemotherapy at that point is not unreasonable, and try basically to alternate. This patient already received chemotherapy, so we don't know how it's the neuropathy and what toxicity they have as leftover from their cisplatin, and how willing they want to undergo taxane, lose their hair, and get more neuropathy. And that's why using the ARV7 is kind of a way to make the recommendation more justifiable, to convince the patient one way or another. Also, since we already talked about PSMA, now there are many PSMA-directed therapies that are available in US and in Europe. A few patients actually are flying to Germany to get those PSMA-directed options, and many sites are opening that, and I feel people ask for those trials more and more. So I will have a conversation about all this.
Yeah, well, I think the good news is there's a number of options, more hormones, chemo, radium. Obviously, this patient is not a candidate because of the lack of bone disease, but just sort of speaking in general terms, I would probably start to think about sending Tempus or some sort of genetic testing on this patient. If they're MSA high, they can get pembrolizumab, et cetera. So there are a lot of options. I'm not sure that there's one. Just to summarize, I'm not sure that there's one option for this patient, and it probably also depends on sites of progression. Is it symptomatic? Is it a more indolent progression? Do they have a 5-year response to initial hormones where you might be likely to try more hormones? So I think it's a little bit undefined, but I think there's more and more expanding options in this disease.